Good morning, friends and colleagues of the World Health Summit 2022. It's my absolute honor and privilege to welcome you all to this session called New Voices in Global Health. And this session is a collaboration between the World Health Summit and the Global Young Academy, the GHI, and where we're early to mid-career scientists from the GHI and various national young academies actually apply, and they're selected to present their leading thoughts on global health of current and future importance. So this year's topic is COVID-19 and antimicrobial resistance, and we will be discussing the connections and consequences. So the antimicrobial resistance, we will be saying AMR interchangeably, and the Global Young Academy, we will be saying GYA in various places. I'm Pradeep Kumar from Wits University, South Africa. I'm a pharmacist by training and a member of the GYA and the South African Young Academy of Science. I will be co-chairing with two very esteemed friends of mine, Stephen Kohler from the GYA, Global Young Academy. He's from Germany, and Karen Kluta, a member of the GYA and the South African Young Academy of Science, and she comes from University of South Africa. Karen is joining us online from the beautiful city of Cape Town in South Africa. So thank you, Stephen and Karen, for your help in preparing this session and planning this session. So we have 5 speakers today, which will be presenting their respective work on topics ranging from challenges to solutions, as well as prescribing behaviors, neglected links, dysbiosis, as well as biocides misusage. So, and we will have some time for a couple of questions after each talk. So we have 5 talks. There are time for a couple of questions from the audience after each talk, and then we will have a discussion at the end of all the talks. We have a question round as well from online co-chair, as well as we have question round from the online community as well. So our first speaker of the session is Andre Molnar from Australia. Thank you.
So good afternoon, everyone. Oh, this is a bit too high for me. So I'm going to make a brief introduction into why AMR and what are the challenges and solutions out there. And while the slide is moving, I'm located at Swinburne University of Technology in Australia, and I'm a member of GHI since 2020. Okay, thank you. So why AMR? So it was estimated that if we don't address antimicrobial resistance, it will result in 10 million deaths by 2025. And it's estimated that it will cost 66 trillion pounds by then, the consequences of dealing with AMR. Now, we have done since then some progress, but also COVID pandemic has offered some setbacks. And there are complex reasons why that has happened. So you might think that, yes, we will discover new drugs and this will help. And that's true, this will help. But there are complex reasons of why we discover drugs a bit slower nowadays, and why we need to focus on preserving existing antibiotics. And part of the reason is the more we discover drugs, if we misuse them, the faster we basically need new drugs. So we need to develop faster and faster new drugs because we develop resistance. Now, there are complex reasons behind it. Part of it is some sort of misunderstanding of why antimicrobial resistance occurs within the population. So there is a lot of misunderstanding between whether antibiotics are effective or not against viruses. So people tend to believe that you need antibiotic when you're infected with a virus, and they want a prescription for it. It's also a bit of a complex topic to be understood. A lot of people assume that you as a person become resistant to antibiotics rather than the bacteria becomes resistant and the bacteria can be transferred. there is also sort of positive feeling, like we all believe that somebody will find a solution, somebody else will find a solution, and we can do whatever, because, well, some other people are taking care of this. Now, we have antibiotic prescription guidelines, and that's great, but often they are not always applicable in local context. And in that local context, doctors might be reluctant to follow the antibiotic prescription guidelines because they felt like in this context, they don't apply. So we need both like a global level, of course, of addressing these issues, but also being flexible and adaptive to the local context on which we prescribe those antibiotics. Now, COVID-19 has posed a few challenges. And there are more complex reasons of why antimicrobial resistance, some say increased during the COVID-19. And one of them is the difficulty of distinguishing between the COVID symptoms and bacterial infections. So people are going with, who have COVID, they are prescribed antibiotics just in case. Now, as controversial as this may be, vaccines could help reduce the risk of using too many antibiotics because you don't end up in the hospital and you don't end up with severe cases of COVID-19. We also need to consider that we live in a complex environment. So we live together with animals. We live in an environment in which we have antibiotic pollution. We consume antibiotics through the food that we get. And all this needs to be taken into account when we address AMR. So it shouldn't be just a focus on the prescription on human, it should be addressing all these issues together. But we also need a global approach. So we need everybody to do something about it. So it's not enough that a few countries address these issues. We need a global approach to address it. There's been a lot of work done, especially in antibiotic prescription for humans, like a lot of work done to try to reduce it and try to create awareness. However, traditional healthcare campaigns, and by traditional healthcare campaigns, I mean leaflets, TV advertisement, usually produce mixed results. And I believe, and some others believe, that we need a variety of approaches to engage people with. So we need to involve different disciplines together in order to reach different groups of people who might engage in different ways. And one of the projects that I work in is called GASDA, and it's looking at how we can engage people with prescribing antibiotics using gamification. So basically, it's a mobile application designed for surgeons, and in which the surgeons input basically the data about the patient, and they are told whether their prescription fits between the guidelines. We use different forms of gamification in that, and we try to engage the surgeons both within the app. So we have rewards within the app and also outside the application. So inter-hospital competitions, for example. So different hospitals using the application, which hospital kind of gets better at following the prescription guidelines. Now, we tested this in 3 different hospitals with different surgeons, different career levels. And we found out that in some cases, we actually get doctors to change their non-compliant prescription guidelines. So if what they input wasn't compliant with the current antibiotic prescription guidelines, sometimes clinicians change their responses. Now, there were reasons why they didn't want to change them when they didn't. So we suggested the surgeons, the app suggested the surgeons that you might want to change this one to be in accordance to guidelines, but it wasn't imposed. Now, among the reasons why clinicians didn't go for existing prescription guidelines is that you usually have a local practice, which is often unwritten. So there is an understanding that we will follow these guidelines in our local hospital. They found that international guidelines are often not applicable to their context. And they were very focused on prevention. So they want to prevent an infection happening now rather than risking to have an infection later on. And this project was done in collaboration with a lot of people. So thank you to all of them. And thank you to you for following and listening to me.
And thank you, Andrea, so much. And we would like to have some questions or comments from the audience, if there are any.
If not, can you tell me how many of you have played games? Oh, thank you. How many of you love playing games? Okay, so what I'm doing basically in my research, I'm looking into how we can use elements from the games or games to engage people with complex topics, and antimicrobial resistance is one of them. So my passion is into looking into how can I make people so engaged, like they really don't want to give up learning more about something. Now, this is challenging, of course, because games are there for entertainment. So it's a bit hard to combine the both. But it's also, I think, a different avenue to try to engage people who otherwise might not be engaged in this topic. Yes?
Sorry for the microphone.
Did you have any pushback from maybe older surgeons or people that have maybe already been set in their ways and how they're already prescribing?
Yes and no. I think we have a bit of pushback from everyone, like a little bit, but it wasn't. I think we made it clear from the beginning that it was there as a recommendation. It wasn't there as imposing to change your decision. So you as a surgeon know better. And the application was just there for you to give your suggestions. And most of the feedback ended up being very positive and people being happy to engage and have a refresh of the existing prescription guidelines.
Hello, thank you for the really insightful presentation. I'm just trying to consider this topic within my region, which is the Middle East, Kurdistan region. And one of the major issues we have with AMR is that there is no regulation of our medical prescriptions. And I wondered if you'd ever considered addressing the issue at the source, which is from the pharmaceutical industries and companies that are providing those medicines, because I think they'd have a lot more power than our current system does in distinguishing what should be done with the actual medication, how it should be distributed. Have you ever considered maybe, or does your project include this particular concept?
No, I'm not looking at the policy, unfortunately, but policy is very important. So having prescription guidelines, it's very important. Reducing access or make it not so easy for people to buy antibiotics over the counter. It's one of the very important aspects of AMR. And I think some countries do it better than others, but we need a global approach if we want to address this problem. Like, we cannot have it just a few countries trying to do it and others not, because it's a global problem, so it won't work otherwise.
Okay. Sorry, we will have questions maybe at the end of the session as well, because we have 4 more speakers. Okay, thank you. But I'll have a note.
Thank you all.
Thank you.
And if not, I'll follow up with you at the coffee break or the lunch break. Thank you.
Thank you so much, Andrea. So thank you, everyone. And our next speaker is Nurul Islam from Bangladesh, and he's joining us online. So I'm not sure if he has joined as yet. No, so he's not joined. Maybe he's having some online difficulties. So we'll move on to Riza Afshari from Canada. Thank you.
Good morning. This talk is about the COVID-19 and what has happened as a result of this pandemic on drug resistance, antimicrobial resistance. So I tried to put some infographics to make the concept more easy to transfer. So you see the ugly shape of the virus in the left, and on the right is the infographics for the microbial resistance. The one topic that I'm going to discuss this is the reasons that is attributed to visible minorities and ethnic groups in high-income countries. So if you see the population and there is one minority which the color is a bit dotted, so we want to see how it moves when as compared to the general population. As for declaration, I'm an alumnus for the Global Young Academy. It's very good to feel young again, and I'm very thankful for being invited here. I have ties with different institutes, industry, academia, and scientific boards. So, but none of them has affected this talk, and I have no conflict of interest to declare. At the same time, the views that are presented are only mine, is not representative of the organization that I'm working with. You see that antimicrobial resistance is a catastrophe. It is affecting everyone. Why and how? First, because it causes deaths. Worldwide, 1 million deaths are reported attributed to antimicrobial resistance. It's a huge number. Also, Andrea talked about the costs. It's exactly the case. So it's very expensive. It comes with 20 billion per year in the US alone. So a disaster. The other problem is it is expected to grow. By 2050, tenfold increase in the next 30 days. So it would be devastating even more in future. So we have to have some problems, some process in place to resolve the problem. There are facts. If the prescription rate of antibacterials increases, the rate of resistance to antibacterial increases. So the goal is to avoid not necessary prescription of antimicrobials. Secondly, when the COVID pandemic happened, the rate of prescription jumped up for good reasons and for bad reasons. There are some super infection that happens. So in that case, we need to prescribe antibiotics. However, many physicians prescribe preemptively and for the situations that are not needed. In the study that I quoted from Lancet, 72% of COVID cases received antibiotics in that period of the study, particularly in the first year of the pandemic, but only 7% needed it in reality. We are expecting that the prescription rate is more than what is needed, but tenfold different is a lot. So to summarize this, you see in the infographics that the ugly virus pandemic has caused increased prescription of the antibiotics that led to the resistance. The increased rate of prescriptions is for right reasons and for bad reasons. We have to avoid the bad reasons when they are not necessary. Another fact is about the minority groups. When we're talking about the communities within the general population, we are looking at it from different sides. They are racial groups, ethnical groups, and include a variety of the situation. For example, in Canada, the life expectancy for the population from the source that I selected is around 81 years. The life expectancy for Aboriginal population is 73 years. There are different references, which is a bit different. So it's huge. There is a gap between the communities, and it's a place, it's a point that we can intervene. Another issue that we have to keep in mind is that in the past 50 years, the gap between the low-income and middle-income countries and high-income countries decreased considerably. So the infant mortality rate in the high-income countries are still better than middle and low-income, but the gap is much less as compared to 50 years ago. However, the difference in the high-income countries between the communities and the general population, although decreased, is not as effectively decreased as the international gap. So basically, it's a point of intervention to help the communities. I would say some of the aspects, communities within the high-income countries has improved dramatically. Some of them didn't. There are reasons that are unavoidable. I lived in an area that aflatoxin exposure through food was very common. After I immigrated somewhere, that aflatoxin is no longer the case, so exposure stopped. But my past exposure when I grew up still has increased the rate of cancer in me, could increase the rate of cancer. So some of those are not avoidable, but some others are avoidable that should be worked on. Why they are different? For COVID, the rate of catching the disease has increased dramatically, more than the general population. First, because the labor market is different. It's not a genetic issue. When the pandemic happened, many people worked from home, but the bus drivers, the people who work in grocery stores, they have to work. They are essential workers. And disproportionately, they are from minority groups. So the exposure rate between them and the general population is higher. There are other reasons. There are super spreaders and the others. Minorities also have higher, more severe cases of disease. It's because the rate of diabetes, obesity is higher. So it's much more than that. This is my last slide. A summary and infographics of what has happened. There are 5 columns. On top, the first one is the general population, the black, and the dotted person is the minority groups within the general population. And I'm looking for your input if you have any reason that you think could be justifying the differences that we have. So in the second column, the rate of COVID, the prevalence of COVID was higher in minority groups. The severity, as we discussed, was higher. Antimicrobial prescriptions is higher. That's, if you are working in the high-income countries, you can see that the minority people, like, from the nationality that I am, when they are coming for cough, they expect to receive more antibiotics. That's not the case for the general population. For many reasons, antibiotics are being prescribed more than that. And for all of these reasons, it is much more, not much, it's more common that drug resistance happens related to the minority groups. Take-home message is this: we need to gather information for the minority group. We need mini surveillance systems for the minority groups in high-income countries. It's not related just for the antibacterial resistance, but it's related to any other pandemic or any other conditions. If you want to study more, I have a commentary in BMJ has published. These information are there. You can read those. Thank you.
Thank you so much, Riza. We have some questions from the audience. Yes, please. There's a question at the back. Thank you.
Thank you for this very informative speech. My question, there is a window between mild and severe cases with the virus infection. For example, for H1N1 and for COVID-19 and etc. And mainly the cause of transforming from mild to severe, it is secondary infection. It is not due to the viremia or due to the immune system response. So this is the two major issues for performing it to severe one. So this window is very important, and we have to know when it is, we have to get, and when there is a benefit from antibiotic prescription. If we prescribe antibiotic lately, there will not be a good response for this. So I think from my experience, when there is leukopenia with lymphos, with the neutrophilia, this is one of the major issues which we have to give antibiotic. When there is, especially for pregnant women, hypertension without symptoms of BET, pregnancy-induced hypertension, like uric acid high or etc., we have to give antibiotic. And this is when we give it at this momentum, we can overcome the disease. When we leave it at this momentum, there will be a serious complications. So I think we now we need more classifications about the symptoms and when to give antibiotic. And sometimes it is very important to give antibiotic to save the life of the patient. But we have to know when to give it and to whom to give it. Thank you.
Thank you. Very good comment and question. That's correct. Physicians are autonomous because of that. There are some reasons that we have to prescribe antibiotics. If it's justified, it must be done. We are talking about the situation that it's not needed, and there are guidelines available that can justify when and how you should start antibiotics. I totally understand your point, and it's right. There are legitimate reasons for prescribing antibiotics that they shouldn't be jeopardized.
Thank you so much, Riza. It was amazing. And now we know physicians are autonomous and we need more classification. Thank you. Thank you so much. Our next speaker will be Angelica Vieira from Brazil. Thank you.
So first, thank you for the organizers to be here. And I think I will present to you today some new perspective of how the consequence of COVID-19 can be connected to antimicrobial resistance through by dysregulation of gut microbiota that I want you to understand. So I'm Angelica, I'm professor at the Federal University of Minas Gerais in Brazil, and I'm here represent as a younger member of the Brazilian Academy of Science. So it's my honor to be here. I think I'm the only Brazilian that is in the conference. So I will start just to saying that during the coronavirus pandemic, another microorganism has been gained prominence, that is the bacteria. So I'm not sure if you are aware that we care a lot of trillions of bacteria in your body, that most of them are in our gut, and they form a very complex ecosystem that it's very important for the host. So we know already that these microorganisms, this population, have several beneficial effects for us, as, for example, synthesize vitamins, but they also are very important to contribute to the gut homeostasis of us. And it is important that this population has been in imbalance with our body, because we know that any alteration or unbalance on this population can contribute to the development of many diseases. For this, we used to say that we are married to our gut microbiota because they are present for rich and for poor, but they also are very important to the sickness and also for the health of individual. And we know that keeping this balance of these microorganisms is very important, and there is a lot of factors that can disrupt this balance. And during the pandemic, the coronavirus pandemic, there is several factors that I highlight here that was important to contribute to this disbalance of the gut microbiota. And of course, the overuse and indiscriminate use of antibiotics, especially in my country where they use the prescription of antimicrobials in general was very high consumed as a preventive treatment to COVID-19. And but also what is important to say is that the infection, the SARS-CoV-2 infection per se, it's also contribute to the alteration of gut microbiota. And also the changing on the dietary habits that we have during the COVID-19 contribute to the alterations of our gut microbiota. So lead to the dysbiosis of this. And what is the connection of the dysbiosis to the AMR connection thread? So what we have been found in your lab that we use an experiment and saying that when we have dysbiosis of this microbiota, we favor the overgrowth of bacteria that can cause us disease. But what is more important, that most of these bacteria that overgrow when we have this disbalance, they carry a lot of resistance genes. So this means that these bacteria that are overgrowth when our gut microbiota are altered, induced by COVID-19, they are important reservoir of resistance genes. So this is particularly important because we know that the overgrowth of these bacteria in the feces, in the gut, they can be in the context of One Health context, since we know that the feces go to the sewage and then can contaminate the environment. So this is a very big issue that we have been seeing, that others research groups have been showing that we call them the silence pandemic because we are spread this bacteria, resistant bacteria to the environment. But we explore in the lab, we go further to understand what is the consequence of this increased phenotype of antimicrobial resistance bacteria in the gut. And what we did, we collect feces from individuals that have been infected by COVID-19, and together in concomitantly we collect feces for control individuals that have never been exposed to the SARS-CoV-2 infection. And what I want to highlight here is that these individuals, they are asymptomatic or mild symptoms. So there is no feces collecting from individuals that had moderate or severe symptoms of SARS-CoV-2. And what we found first is that the gut microbiota of these individuals were altered, induced by the SARS-CoV-2 infection. And this alteration persists even when the people clears the virus. So when we collect the feces and we did a transplant to mice in the lab, so we did a fecal microbiota transplant to mice in your lab, we found and we infected these mice with antimicrobial resistance bacteria that was a Klebsiella pneumoniae multi-resistant strain that, just for information of you, this is a bacteria that are present in most of 17% people in the world, in all the world. And we found that these mice were more susceptible to the infection, to these infections. So what I'm telling you here is that the alterations induced by COVID-19 in the gut microbiota, they impair our immune system how to deal with an infection induced by antimicrobial resistance genes. So again, this is a very bad information that we have because now we know that we need to think about strategies to modulate our gut microbiota to try to restore the homeostasis of this microbiota, to try to engage our immune system to how to deal with one infection. So I will finish here with my take-home message to you, just to think about that. Of course, we need to increase campaigns against the overuse of antibiotics for sure, but we also need more financial support for research, basic research, to understand the mechanisms that goes toward the gut microbiota and IMR connection. But we also know that we can start changing small changes today, for example, by engaging us, individuals, to change our lifestyle. So by changing things that we know that is important to modulate and to restore the balance of our gut microbiota. And how we can do that? We can do that by starting just changing the eating habits. So getting more fresh vegetables, fresh foods, and with high fiber diet that we are already know that is important and contribute to restore the gut microbiota balance, and also to improve our immune system to how to deal with infections of difficult treatment as an AMR infection, and also to include health apps that, for example, include sports in DAO, that could be very important, and keep our mental health, that I know that's very difficult today, but this is something that we need to think about that. So I would like to thank you, all the audience, and I'm very happy to get questions for you.
Thank you so much, Angelica. Lifestyle is a big contributor. And I must say this was an interesting experiment. So can we take some questions from the audience, please? Okay, we'll maybe have questions later in the discussion section. Thank you so much, Angelica. So our next speaker is Fatima Mohammadipana from Iran. Thank you.
Big thanks to the organizer and welcome to you. I start my talk. If I could see my slides. I want to address this question in my talk, that is there any correlation between using sanitizer and the risk of increased rate of antimicrobial resistance? We were told that it's a bit slow and we must be patient.
Restart the document system. So if you would bring it without presentation or bring it up as soon as possible.
If I understood properly, you mean that I can start till that?
Yeah, you can. Look, it's here now.
You know that antiseptics and disinfectant are referred as the general terms of biocides, and they are used for more than half a century for decontaminating water, foods, wounds, and devices. And during the COVID-19 pandemic, you might have heard that we have more than 500 approved products of biocides, which are mostly based on quaternary ammonium compounds and peroxide hydrogen and ethanol and so on. Seems that my slides are not coming along. Oops. The thing is that these biocides have toxicity for our body and also the environment. They can increase the production of reactive oxygen species and also induce apoptosis and make some imbalances in the concentration of vital ions. So we know that these chemicals as biocides have inherent toxicity, and we must somehow limit their consumption. But the message that I want to talk in this presentation is that now we have come to the conclusion that there is a correlation between the resistance to antibiotic and the usage of biocides. Means that AMR bacteria can be evolved or emerge by the selection pressure imposed by biocides. So if we don't care about the excessive usage or misusage of disinfectants and antiseptics, we are contributing to the increased rate of antimicrobial resistance. Some of the chemical bases of biocides like triclosan or chlorinated one also increase the rate of horizontal gene transfer between the bacteria. But what will be the solution? I can categorize the proposed solution in 3 items. First, we can use the chemicals as biocides, which are less prone to induce the antimicrobial resistance. For example, peracetic acid, isopropanol, or some other one are less toxic than the chlorinated one, or quaternary ammonium compounds, which are commonly used in this product. So the first step is that try to use the one which have a less chance for the co-selection of AMR strains. The second approach can be using other compounds, preferably natural compounds, to increase the efficiency of the chemical biocides at lower concentration. Means that we can find compounds from natural origin. Those have synergy with chemicals and can allow us to use less than these toxic chemicals for the disinfection. This is a topic that my research lab is working on. And the last approach can be maybe legislation and monitoring of the misusage of disinfectants. So we can, by this approach, limit or reduce the concentration that is used, maybe because of the lack of knowledge or OCD-related issues. So we also need legislation and monitoring for the concentration and the actually a scale which is using in household or industry and also healthcare systems. Thank you for attention. And at the end, or maybe now, I am ready also to listen to your comment. Thank you.
Thank you, Fatima, for reiterating One Health approach. Are there any questions for Fatima? There is a question for you. Thank you.
Thank you so much for this presentation. I have a quick question about the solutions that you mentioned. I would like, if possible, to explain maybe in layman terms. For example, the alcohol-based hand sanitizer, is that good or bad? If it's bad, then what should we use in its place in terms that we can understand?
Yes.
Thank you.
Actually, ethanol is among the products, which is at the higher rank of the consumption. Its good trait is that it is more prone to evaporate, so it has less chance to penetrate to the epidermal, and so it's less toxic compared to the chlorinated or ammonium quaternary compounds. So we can say that it's moderately toxic, but the dosage and alternative that we are using must be cared, because some people, it's kind of the habit that they are just like urged to do that. They have maybe not been at a real risk, but they use it in a very frequent way. So it must be trained or somehow stopped to use in this manner.
Thank you so much, Fatima. If there are no more questions, then we can go to our last speaker. I have messaged that Nurul is online now. And thank you, Fatima. Thank you for an interesting talk. We'll have more discussion now. So Nurul Islam is from Bangladesh and is joining online. Thank you.
Okay. Hello world. Hello world. Greetings from Bangladesh. Is it okay? My sound is okay?
Yes, the sound is okay. Thank you. Go ahead.
Okay, thank you. I am Muhammad Nurul Islam from Bangladesh. I'm member of National Young Academy of Bangladesh, and now I am doing my PhD in Nanjing University, China. Unfortunately, in my name, there is written Dr. Nurul Islam. I'm not a doctor till now. I'm delighted to share our work. It's our teamwork. Other two member, MD Monirul Islam, librarian, Army Medical College, Bangladesh, and our team leader is Dr. Jannatul Firdaus, Associate Professor, Department of Pharmacology, BGC Trust Medical College, Bangladesh. And my topic is antimicrobial prescribing behavior in COVID-19 patients, a multi-centered survey at tertiary care hospitals in Bangladesh. In 2019, the world has experienced a terrifying foreshadowing a global pandemic caused by novel coronavirus known as SARS-CoV-2. Controlling the spread of infection, developing treatments, and vaccination were the main emphasis of the global action plan. The COVID-19 virus can produce an acute respiratory illness that is difficult to distinguish from bacterial infections and can result in secondary infections. As a result, antimicrobials were routinely recommended for a variety of reasons. It might aggravate the global problem of antimicrobial resistance while also rendering presently accessible antimicrobial ineffective. As a result, the current pandemic's consequences may extend into the post-COVID-19 era. Henceforth, we conducted a survey to learn more about antimicrobial prescribing behavior in COVID-19 patients among 74 physicians from 12 hospitals in COVID-19 patients. By evaluating the trends and predictors of antimicrobial prescribing practices in COVID-19 can aid in identifying intervention opportunities to improve rational use. In Bangladesh, all patients admitted to the hospital were routinely given broad spectrum antimicrobials. This table showed that meropenem, azithromycin, ceftriaxone, and even linezolid also prescribed in COVID-19 ward without proper evidence of bacterial infection. Whereas World Health Organization identified ceftriaxone, vancomycin, azithromycin, tizicelin, and linezolid as critically essential antibiotics for humans. This table showed antibiotic prescribing in intensive care unit of COVID-19 patient. Here we also see the same pattern. Meropenem used almost 84% case, followed by the linezolid and piperacillin and tozavectam. So the main findings of the study is 69% physician administered.
Sorry, Nurul, your slides are not moving. So we are still on the first slide.
It's maybe because of technical problem, but
Can you share the slides?
yeah.
From your side?
Now,
Yes, now we can see we are the fifth one now. Thank you.
so the main findings of the study is 69% physician administered antimicrobial drugs to hospitalized COVID-19 patients. Only 14% physician did not initially provide antimicrobials to COVID-19 patients. 69% stated their hospitals has no local guidelines. It is evident that the dearth of local clinical guidelines for managing COVID patients may lead to inappropriate antimicrobial use. Thus, exacerbating the AMR problem. 67% stated antimicrobial therapy was 7 days, and some extends to 10 to 14 days. More than 50% mentioned epidemic antimicrobial treatment was necessary for treatment of secondary infection, mostly with Pseudomonas aeruginosa. In COVID-19 ward, meropenem and ceftriaxone widely used. In ICU of COVID-19, meropenem, linezolid widely used. So, unguided and pointless use of antimicrobial throughout the COVID-19 period in Bangladesh conceived a circumstance where future of antimicrobials are at a stake. Therefore, the findings of this survey can create an impulse to launch a successful antimicrobial stewardship program, which will allow physicians to prescribe judiciously. So, our recommendations are launch antimicrobial stewardship program, reduce unnecessary antimicrobial prescriptions, implement educational strategies such as academic detailing and educational workshops should be implemented in each hospital based on its specific resources. Thank you. And I'm requesting to our lead investigator, Dr. Jannat Al-Firdaus, to handle the question and answer session.
Thank you so much, Nurul. I think 4 out of 5 speakers mentioned prescriptions. So it's really an important issue, and I will welcome any questions from the audience for Nurul. And so there were 70% saying there were no hospital regulations or guidelines to follow, and so it's really an issue in low-income countries. I can see that. And so if there are no questions, then we can go for a quick round of questions from our co-chair from Cape Town, Karen Kluter. And she has some very interesting questions for the panelists. Thank you.
So thank you
Karen,
very
you're
much.
online.
Thank you very much, Pradeep. So good morning, esteemed colleagues, co-chairs and panelists. And thank you so much for this very fascinating and interesting talk. So Andrea, I'm going to start with you. Thank you very much for your fascinating talk on the challenges and solutions for antimicrobial resistance in the COVID-19 context, with the important message that we need a multifaceted and multisectoral approach to reduce antimicrobial resistance. So can you please explain to us, firstly, what multifaceted approaches can be used to reduce AMR? And secondly, why is a multisectoral approach important to reduce AMR? So I repeat, first question, what multifaceted approaches can be used to reduce AMR? And secondly, why is a multisectoral approach important to reduce AMR? So thank you, Andrea, over to you.
So by multifaceted approach, I mean, we need a bit more than traditional healthcare campaigns. So we need a bit more than passive way of delivering information. So we need to find different ways to engage people with this topic if we actually want something to change. And I think we want both people to have the knowledge, but we want them to go further than the knowledge. We want them to change their behavior. So that's why I say that we need a multifaceted approach. My approach is to use games or gaming kind of solutions because I'm a bit biased and I like games. And I think there is something out there. But there are also other ways. And I think we need to involve different disciplines and engage different disciplines into this fight against antimicrobial resistance. Multisectoral, I was thinking about that by using a One Health approach. So considering not only antibiotic resistance in humans, but considering that we use a lot of antibiotics in animals, for example. And those are, there is not that much regulation on using antibiotic resistance in animals as there is in humans. There are a few countries who are doing great, but mostly we don't really have much on that area. And we know that we consume antibiotics through our food, and there is increasing evidence that might contribute towards antimicrobial resistance. We also pollute our environment with antimicrobials. And though, for example, we filter our water, we don't have a way to filter our water for antibiotics. So if we pollute our environment, we might also get it back through our water or to other different means. So we need to look at all these aspects. We cannot just look at one single aspect. And I think that I think and I hope that will help reduce the rate at which antibiotics becomes useless in certain cases.
So thank you very much, Andrea, for these comprehensive answers. So let's move over to our second speaker, Riza. Riza, thank you very much for your important talk. Now, with one of the conference themes being health equity, you highlighted in your very important talk entitled COVID-19 Exacerbation of Antimicrobial Resistance, Neglected Links and Consequences with Racial and Minority Groups in High-Income Countries. And here you highlighted specifically that there's a need for a targeted pharmacoepidemiological surveillance system on the impact of COVID-19 on AMR specific to visible minorities and at-risk populations and sensitive populations. And you also highlighted that prioritizing these communities for education and vaccination are extremely important. So thank you very much for highlighting this. And our question to you is, does this gap apply to other diseases and health conditions? And secondly, is the health gap between the general population and minority groups in high-income countries increasing or decreasing? So I repeat, does this gap apply to other diseases and health conditions? And secondly, is this health gap between the general population and minority groups in high-income countries increasing or decreasing? So thank you, Riza, over to you.
Thank you, very good question. Actually, it is important to communicate with wherever we can make more impact. So during the COVID, it appeared that COVID is not fair. It's not a fair disease. It impacts the less privileged more. It impacts the further communities from the city centers when they are far more. It impacts some of the cases with diseases more. So we have to be aware of that and make any contribution that we have, any intervention that we plan to the point that has the highest possible impact. It is important to try more to get rid of the gap between the minority groups and the rest. One example was the vaccination. We campaigned based on the work that we did that the minorities should be prioritized for the time of vaccination. If you remember, majority of the vaccination prioritizing was based on age. After a while, we showed that some of the minority groups are in more need, so they should receive vaccines earlier, and that has happened for some communities. The gap exists, as to the second question, it is decreasing in some aspects dramatically. It's good news. The communities are approaching to the level of the general population. For some aspects, it doesn't. There are some variables that have been shown that the gap is actually increasing in the past few years, which is very important. So the answer is mixed. While the general approach is that the communities are reaching out to the general population, the speed is not enough, and it's not the same for all the health variables that we have studied.
So thank you very much, Rita. So let's move over to Angelica. So thank you very much, Angelica, for providing a multidisciplinary angle to the session through your talk entitled The Dysregulation of the Gut Microbiota Induced by COVID-19 and How It Contributes to the Selection and Dissemination of Antimicrobial Resistance. And here you highlighted the importance to considerate strategies of gut microbiota modulation to prevent or decelerate the spread of AMR bacterial genes, but also call for using these strategies such as health diets as alternatives to treat infections caused by AMR bacteria. And we would like to ask you specifically, firstly, can we use the gut microbiota as a target to prevent or treat antimicrobial resistance bacterial infections? And secondly, what are the mechanisms towards the impact of the gut microbiota disbalance induced by the COVID-19 on lung immunity against AMR bacterial infections? So let me just repeat those two questions. Can we use the gut microbiota as target to prevent or treat antimicrobial resistant bacterial infections? And secondly, what are the mechanisms towards the impact of gut microbiota disbalance induced by COVID-19 on lung immunity against AMR bacterial infection? Thank you, Angelica, over to you.
Thank you, Karin, for the excellent questions. First, that's the idea. We think that we need to consider the gut microbiota as a target to treat it or to prevent the dissemination and selection of antimicrobial resistance bacteria. So what we have been looking for is if any strategies, as for example, using probiotics or other commensal bacteria that are high expressed in healthy individuals, that this can be used as a therapy instead of using others drugs, for example, to treat infection disease. So we have like promising results in the lab showing that using probiotics that can be helpful to help to control infections induced by antimicrobial resistance bacteria. So the mechanisms that we are believing on that go for in more details because we know that, for example, beneficial bacteria that are in your gut, they produce a lot of metabolites when we eat, for example, fiber. And these fibers serve as food for these beneficial bacteria. And when they produce these metabolites activate our inflammatory cells, and they help our immune system to to fight against bacteria. So what I believe is that we can use our body, your immune system, to look at targets, specifically targets of our immune system, to make them stronger and to deal with infections induced by antimicrobial resistant bacteria.
Thank you, Angelica. Thank you very much for that interesting answer. So we're almost at towards our final speaker, but let's first move to Fatima. So thank you very much, Fatima, for your fascinating talk on the post-COVID-19 and consequences of biocide misusage, in which you highlighted the importance of increasing awareness on the consequences of overusing disinfectants and antiseptics in post-pandemic years, which leads to a toxic effect on the ecosystem and human health, highlighting this very important One Health approach. So we would like to ask you if you could please explain to us the main mechanisms behind the toxicity of antiseptics and disinfectants. And secondly, can we consider nanomaterial-based antiseptics as alternative to current formulations to avoid increased antimicrobial resistance? So let me just repeat those two questions. The main mechanisms behind the toxicity of antiseptics or disinfectants, please explain that to us. And secondly, can we consider nanomaterial-based antiseptics as alternative to current formulations to avoid increased antimicrobial resistance? So thank you, Fatima. Over to you.
Thank you, Karen. In response to the first question, there is overlapped or cross mechanism between the way that bacteria are get resistance to antimicrobials and biocides. So means that they are either changing their molecular target inside, or they are using some approaches to exclude the compound from the penetration to the cells, like modifying the cell line and using the efflux and so on. And the mechanism are quite similar. So if we don't care about the misusage of biocides, we are actually helping to the increased rate of AMR. And in response to the second question, I think it was the second approach I mentioned among the 3 solutions that I suggested. If we are expecting antiviral or antibacterial activity from biocide at a certain concentration, we can reduce it by using some other compound which are helping the chemical agent, which can be from natural resources in a mechanism called synergy. By this approach, we can discharge less amount of biocide to the environment and also expose ourselves to the less concentration of the antiseptics or disinfectants we are using. Thank you.
So thank you very much, Fatima. So let's move over to our youngest presenter here today, Nurul. Thank you very much for your interesting talk entitled The Antimicrobial Prescribing Behaviors in COVID-19 Patients. And you gave us the main message that implementation of antibiotic stewardship programs in hospitals and improving educational strategies that will help physicians to prescribe appropriately antibiotics is very important. And we would like to ask you, are there any recommendations for improving physician antimicrobial prescribing? So either you or your supervisor can answer this question. Is there any recommendations for improving physician antimicrobial prescribing? Thank you, Nurul. Over to you and your supervisor.
Thank you for your question. We have 4 recommendations. 1, follow the strict antimicrobial guidelines. 2nd, only use antibiotic when proven indication or secondary infection. 3rd recommendation, improve hospital infection prevention facility. 4th, our patient. Thank you for your question.
So thank you very much, Nurul, and thank you very much to all the panelists providing those comprehensive and very interesting answers to these very diverse and very relevant and very important topics. So I would now like to give Stefan the opportunity to pose some questions to the panelists. Thank you very much.
Thank you, Karen. I think it might be just a good time to ask the audience again, what are open questions for you? I think we have about 5 to 10 minutes for questions from the audience before we conclude with final words. Pradeep, will you continue?
From the audience, yeah, we can get from the back, maybe first.
Hello, Wisdom. Thank you so much for organizing this very interesting session. So my name is Yue. I'm currently a global health master student studying Duke Kunshan University in China. I'm also a University of British Columbia alumni. So my question is to Dr. Afshari. I'm really interested in the question you were talking about pro-vaccination for minority groups. I also want to ask some advice from you, since I also observed that minority communities might be harder to get vaccines in China as well. But some of these people might also be facing other challenges, for example, as awareness and willingness to get vaccinated. And a lot of these minorities might also be migrants to bigger cities. So I wonder whether you have any suggestions or strategies that could also help these minorities who might be migrants or have lower awareness and willingness to get vaccinated to get the vaccination, especially under the COVID-19 pandemic. Thank you so much.
Thank you so much. Actually, that was a very great question. I would summarize this: communication, communication, communication. You know, if you want to have a better outcome, you have to communicate effectively based on the, you know, values, cultural values, subgroups, understanding of issues. If their language is different, it is important to be like that. into the elders is important. Back in Canada, Aboriginal community received vaccination faster than the others, so they prioritized to receive the vaccination. So in action level, they have to be prioritized. In terms of the education and communication, it should be more effective. There is no magic bullet that can be used and solve the problem, but everyone can try as much as possible. Very good question. Thank you.
Okay, thank you. Before I come to you, the third one, a question from second row from here. Thank you. Sorry. Okay. Yeah, fine. First, then I'll go this side. Save time.
Thank you. My name is Mohsen Negari. I am professor of the University of Washington and senior researcher for the AMR that published in the Lancet 4 or 5 months ago. I wanted to say that thank you for this presentation, but there is a big but, because you simplified the problem. Problem cannot be fixed with the game, with the discussion with the people, with the asking the people, oh, do not use antibiotic, or doctor, do not prescribe the antibiotic. No, it's not possible to fix this big epidemic, pandemic that is coming. We have 1.3 million deaths every year due to the AMR, and 4.9 million deaths that is associated with AMR. Is not a small problem. We need a good collaboration, international collaboration from the government. When people do not have health system, they use antibiotic from the grocery store. When doctor, we do not control doctor in our health system, they prescribe. Why we do not have this problem in the high-income country? Because they have a very good health system. Why we had a very small number of the deaths in the Canada, for example, because we passed all of the vaccine to the Canada, not to the India, not to the Brazil, not to the Iran. That is the problem. We do not, all of the time, we find a simple solution. This simple solution doesn't work. If we want to combat with the AMR, we need involvement from the governments. We need involvement from the WHO. We need involvement from the UN Secretary. It's not something that we can fix very easy. It is pandemic that will come. Thank you.
Thank you so much for this comment, and we agree with this. And collaboration and equity, actually both. So Riza was saying communication. I will say collaboration. And an equity is required. And as you said, there's no simple solution to this. We are here to highlight the issues even more from a early career perspective and mid-career scientist perspective. And we do understand as a new generation that new voices of global health, that how do we take it forward? Thank you for your comments. Thank you, sir.
Can I follow?
If you have a quick one, because we have
very quick one. Yeah, I have, Professor. It was a very good point, and that article is a very important one. What I would say is that in low and middle income countries, sometimes there are not regulation. They should be developed. But the most important problem is that regulation exists, information exists, but they are not enforced. So there should be, as you mentioned, by the government, by the authorities, a way to enforce the regulation. If you ask someone in Germany that you can go to the pharmacy and buy antibiotics, no one can believe that. But I know that every medication is available online somewhere else. Very good point. Thank you.
Thank you so much, Riza. We have a question here, and sorry, there's a question from here as well. She also asked you to ask a question to Andrea. Let's go to first to the second row. And then we go at the back to the lady in the white. Thank you.
Thank you. My question goes to Professor Andrea, and I was impressed by your presentation on how you're using games and technology to advance health. And this is a trend that, it's actually a trend now that we are using digital tools and digital solutions for health, but it's actually increasing a lot of diversity and marginalization because not all people, especially in LMICs, can afford or have access to these digital solutions. So we have, increasing barriers, and we are actually increasing barriers to access to health through digital solutions. So my question is, what's your take on how digital developers or computer scientists working on digital solutions for health can actually improve inclusivity to ensure that digital solutions actually do not promote barriers to access to health? Yeah.
Yes. So, well, one of probably quicker solution is to make everything freely accessible. And that would create some access to some people, but will still increase barriers for people who maybe are not that comfortable using digital technology or don't have access to digital technology. And I think, I'm not sure if there is a simple answer to this. I think all of us as developers should be aware that we have an ethical duty to try to make our software as accessible as possible and as ethically as possible. But I'm not sure how we'll increase maybe digital literacy or increasing access to people who won't have access probably to maybe a computer or don't have access to internet. So how do we address that gap is probably a bit beyond my area of expertise, I'm afraid.
Okay, no, thank you so much, Andrea. We have a question from here. The lady in the white suit, if I'm correct.
Thank you very much. My name is Jumana Abdiwani. I come from the Ministry of Health of the Sultanate of Oman. I wanted to thank all the speakers for such an enlightening presentation, and I thought I wanted to share some news with Andrea. You might be pleased to know that the Sultanate of Oman is hosting the 3rd AMR conference. It's going to be building on the legacy that has happened in the Netherlands in the 1st and the 2nd. But the conference in Oman aims to be presenting the concept of One Health and bringing together not only health, because a lot of progress has been made in health in some countries, but also bringing on board ministries of agriculture, ministries of environment, in addition with the quadruped. So we've got the WHO, the OIA, the FAO with us also on board. So you might be looking forward to hearing about Muscat Manifesto. The conference is going to be on the 24th and the 25th of November. And there's a lot of information on the website of the conference. So if you look at AMR Conference 2022, you might be getting some information.
Thank you so much for sharing it.
Okay, thank you so much for sharing. There's a question at the back on the corner from a gentleman.
Yeah, thanks so much. Dr. Charles Chimbugwe. I come from Uganda. I just want to appreciate the presenters, the panelists for this very important. I just want to make this statement. I think the antimicrobial resistance is not being given the attention it needs. And yet, like somebody has said, it would be one of the next global health problem. I looked at very interesting data from the context of COVID. I worked in the COVID world, and those results, really, that's what could happen. Because, for example, during the Delta variant, in most cases, there was a belief from the physicians that the pneumonia caused by the virus would be worsened by the bacterial infection. And therefore, there was usually, most of the physicians would prescribe antibiotic. But I want to say, in the context of of COVID-19, this is a dot in an ocean. The big problem of this antimicrobial resistance in the low-income countries is the root cause is much bigger than that. And I had somebody talking about the stewardship, and which is very important. But how is this? I wanted to ask, how is this rolled out to other countries? What is being done about this? Because it's very, very important. But let us give the attention of this antimicrobial, the attention it needs, because it is scaring to some of us who practice the clinician, because the resistance patterns in the neonatal and other places, it is worrying. Thank you so much.
Thank you so much for your comment, and you're in the right room. Actually, we are actually very, I won't say passionate, but we are concerned about the AMR, and I think our speakers come from developing countries, most of them. Okay, so low income and middle income countries. So we do appreciate your comment, as well as we acknowledge the concerns that you have raised. Thank you so much. So we almost end of the time. I think, and then I will just conclude with a quick sentence. Sorry, maybe if there are more questions we can discuss during lunchtime, but I think I have to conclude the session.